part 3, picking up with breast cancer screening guidelines. There's always a little bit of a difference between what the CDC says and what the American Cancer Society says and what internal medicine docs say. The American Cancer Society always wants to pick up as many cases of cancer as possible. CDC and sometimes primary care docs are a little bit more conservative with what they recommend. And that doesn't make anybody right and doesn't make anybody wrong. It's just, if you don't want to miss any cases of cancer, you screen everybody. But if you screen everybody, you're going to pick up some cases that are false positives, and that's going to worry extra people and test extra people that don't actually have the disease. And that's not always a good thing too. So it's just putting that out there. As I alluded to, the more people you screen, the more cancer you catch, but you also have more false positives, and the more people you worry and the more money you spend. If you screen later, you're going to catch more cases of real cancer, and you're going to worry fewer people, but you're going to miss more early stages of cancer. So it's always things on a balance. And again, no right or wrong, it's just the way things are. So current recommendations that I think most primary care docs are following at this point: if you have no risk factors for breast cancer, so that means no family history, no radiation exposure, no BRCA gene, you're given the option starting at between ages of 40 and 44 to have a mammogram. Between ages of 45 and 54, you should really get one every year, and then every other year starting at age 55. If you're high risk, so think of anything that's a risk factor. You should get a yearly breast MRI. So think about like what would happen if you had your head scanned, and a mammogram starting yearly at age 30, if not earlier, depending on your risk factors. There are some forms of the BRCA gene where some women can, be at risk for cancer in their 20s, but that's something that has to be decided on a more individual and aggressive basis at that point, based off of your history and what's happened with kind of your personal genetics at that point. Screening has helped a ton. The earlier you detect, the better your treatment options are, and the more likely women are able to be cured. And not only that, the treatment isn't so bad. And I even alluded to it with the BRCA gene. It's out there, commonly known enough now that with certain forms of genetic links to breast cancer, it's awful to think about having a preventative mastectomy and have, surgical removal of significant breast tissue, if not the entire breast. That affects lymph drainage. There's pain for the rest of your life after the surgery, but you won't get breast cancer. So yeah, there's been a lot done on the screening front, and there's been a lot done on the public awareness front, where, it's hard to find many women that don't know about getting preventative mammograms anymore. And there's been a lot of public monies and research money thrown down the breast cancer path. So it's, this has been kind of a public health success. There's still work to be done, but it's been a lot better. So 5-year survival rate for breast cancer, and I think the surprises some people, is 90%. Now, again, there's individual cancer types. This doesn't go for all subtypes. There are some that are extremely aggressive that are almost death sentences from the get-go. But if you just say, I have breast cancer, 5-year survival rate is 90%. Local disease, 99% survival rate. This points to screening and better treatment options. Regional disease, 86% 5-year survival. It's only with distant disease where you've got metastases, where it's spread to bone and other regions of your body early on, where your survival rate is well below 50%. Early detection matters, subtype matters. So now we're going to flip to prostate cancer. And in terms of survival, this is kind of the male version of breast cancer. So we'll pick up here when we get back.